I'm Dr. Rapoff of D.C. QME Continuing Education, and welcome to this week's presentation. Today we're going to examine the scientific complexities of myofascial pain syndrome, also known as MPS, and it's a condition that's characterized by hyperirritable trigger points within muscles and fascia. Our discussion today will cover potential causes, symptoms, diagnosis, treatment options for those individuals suffering from MPS. And lastly, I'll walk you through how to approach assigning a permanent impairment rating for an individual diagnosed with MPS according to the AMA Guide's 5th edition. So let's get started. First, the following sources were referenced when producing this presentation. I encourage you to explore these references if you'd like a more in-depth understanding of our discussion today. So as an introduction, myofascial pain syndrome is more than just a clinical diagnosis. It's a multifactorial disorder that's underpinned by biomechanical abnormalities and neuromuscular dysfunction. Clinically, it manifests as localized pain with characteristic referral patterns, but on a cellular level, research points to a combination of ischemia, metabolic stress, and abnormal release of inflammatory mediators. Now, the trigger points may result from a localized energy crisis within muscle fibers, leading to a sustained contraction and subsequent pain. So today we're going to outline the objectives here to explore the basic science behind the trigger points, outline some diagnostic pathways, and review both the conventional and experimental treatments that target these cellular mechanisms. Now, in exploring the causes of myofascial pain syndrome, we really must consider both the mechanical and biomechanical insults. Repetitive strain, microtrauma, and poor postural mechanics lead to the formation of trigger points by basically overloading the muscle fibers, thereby inducing localized ischemia. Now, this results in an energy deficit, prompting an abnormal buildup of inflammatory substances such as bradykinin and substance P, and cytokines that further aggravate tissue sensitivity. Additionally, chronic emotional stress can exacerbate muscle tension through central sensitization mechanisms. And the accompanying table here describes and details these risk factors and highlights their role in triggering the cascade of cellular events responsible for this syndrome. From a clinical standpoint, MPS presents with both local and referred pain. Patients report deep, aching pain that's localized to the affected muscles with distinct taut, tight bands that are palpable upon examination. This pain is mediated by sensitized nociceptors within the trigger points where abnormal in-plate activity leads to local muscle twitch responses upon palpation. Furthermore, the phenomenon is referred pain is explained by the convergence of sensory pathways in the spinal cord, where the signals from trigger points and adjacent regions overlap, misleading the central nervous system about the true source of the discomfort. Diagnosis of myofascial pain syndrome is primarily clinical, yet it benefits from a more scientific approach. A detailed patient history focuses on the activities that induce overuse and the emotional stressors that predispose an individual to sustain muscle tension. The physical examination emphasizes the detection of these trigger points via palpation, identifying the tight, taut bands and eliciting a localized twitch response, and that is a critical finding. Differential diagnosis is also essential. Advanced imaging and EMGs sometimes aid in distinguishing the myofascial pain from neuropathic conditions or even fibromyalgia. The treatment strategies for myofascial pain syndrome are complicated, and they're aiming not only to alleviate the symptoms, but also to interrupt the underlying pathophysiological processes we discussed. Now, conventional therapies include physical modalities like targeted stretching, PT, and manual trigger point release. This helps reduce the muscular tension and restore the normal blood flow. However, pharmacologically, they treat with NSAIDs and muscle relaxants, and they act by reducing inflammation and interrupting the nociceptive signals. Now, in parallel, interventions like trigger point injections or using local anesthetics or corticosteroids and dry needling directly disrupt the dysfunctional in-plate activity. Now, on the horizon, novel approaches such as low laser therapy and extracorporeal shockwave therapy are being explored for the potential to promote tissue repair and to modulate the pain pathways at a molecular level. So now we have a basic understanding of myofascial pain syndrome. As a QME, you may ask, well, how do I rate this applicant who I diagnosed that may be suffering from myofascial pain syndrome? Well, it's not that easy. The AMA Guide's 5th edition does not include myofascial pain syndrome as a discrete ratable diagnosis. It isn't listed in any chapter or table as a standalone condition, so you can't simply plug in MPS and pull an impairment percentage. Instead, you must rate the objective deficits that the applicant demonstrates, like loss of range of motion, a strength deficit, sensory changes, and functional limitations in daily living activities. In the appropriate body part chapters, chapters 15, 16, and 17 for the spine and extremities. And then you assign a whole person impairment accordingly. Now, only after you've established those objective impairments that I just discussed can you, if justified, add a pain added related component under Chapter 18, which is the pain chapter, which relies on standardized questionnaires or functional loss due to pain, never on pain alone. So in practice, then, a myofascial pain syndrome evaluation means two things. One, you have documented objective findings like ranges of motion, strength, sensation, ADLs, and then you assign an impairment rating matching those chapters. If pain still limits function after that, quantify it via Chapter 18 tool, the Pain Disability Questionnaire, and then convert it to a WPI. So this two-step approach is the only way myofascial pain syndrome can really contribute to a permanent impairment rating, according to the Guide's 5th edition. Now for some key takeaways, myofascial pain syndrome encompasses a complex interplay between the neuromuscular dysfunction and biomechanical aberrations. Early detection and a comprehensive treatment regimen combining clinical acumen with evidence-based modalities are essential for the effective treatment. Now, looking forward, future research is likely to focus on refining diagnostic techniques through possibly advanced imaging and biomarkers, as well as evaluating novel, minimally invasive therapies that target the cellular mechanisms underlying the trigger point formation. Continued interdisciplinary partnerships is going to be key in transforming these scientific insights into improved patient care protocols. To wrap things up, having a solid grasp of myofascial pain syndrome, how it presents, how it's diagnosed, how it's managed, matters greatly in our work as qualified medical evaluators. Our job isn't just to confirm whether it's present, but to sort it out from other conditions that might look very similar. Now, by applying our sound clinical judgment, staying current with guidelines, and clearly presenting our conclusions, we will help ensure that the evaluations are fair and accurate. Well, doctors, I'm Dr. Chris Rapoff, and I wanted to thank you for taking the time to join me in today's presentation. I hope you enjoyed it, and I do look forward to sharing other fascinating subjects as they relate to the workers' compensation system in the state of California. Until next time, thank you.